This is the Center of Personalized Medicine, Cardiovascular Module 1. We will discuss the why of personalized medicine in regards to cardiovascular disease and follow that up with Module 2 and Module 3 for details on the Level 1 and Level 2 program. This talk is being recorded March 2018, and I suspect that the opinions and facts may change in short order, maybe 2-3 months. Well, to begin, there are 3 studies that have not been, that are, I think, landmark, but aren't discussed a lot. And the first study was done back in 2009 by Sakura, and it was published in the American Heart Journal. And out of 137,500, as noted on the slide, but out of 137,000 patients who presented to the emergency room or the emergency department for chest pain, 60 to 70% had a heart attack. And of those patients, 75% had an LDL cholesterol less than 130, a LDL cholesterol less than or equal to 143% of those, 70 and 23% of the patients. And most of the patients actually had metabolic syndrome with a low HDL and a high triglyceride. Another study was published in the British Medical Journal back in 2013, citing an unpublished study from the Sydney Heart Study, showing that when flour oil, that the cholesterol did go down, but the cardiovascular mortality rate and events went up. And there was an interesting study just coming out back in September of 2019 in the Journal of Nutritional Biology that used safflower oil and virgin oil and analyzed the effects on rat livers. And all of them caused increased liver fat, but liver damage was much worse with safflower oil, I think, or sunflower oil rather, than the others. Interestingly, fish oil increased telomere length and decreased electron transport activity, although I'm not sure what would seem to be the safest, at least for rats. And then in 2013, Newman did a meta-analysis and found that in at least elderly patients over 65 who had hypertension and high cholesterol, there was no benefit to adding statins, no mortality benefit, that is. And they'd have to treat 140 people to benefit one person. So let's take a look at that. Closer. When you look at statins, yes, there's a lot of data that they do some good. They reduce heart attack risk and primary prevention by 36%. When you look at the absolute risk, the risk of heart attack in the control group is 3%, and in the treated group, 2% over 3.5 years treated with statins. So you'd have to treat 100 people over 3.5 years to prevent one heart attack. There was no mortality prevention, and 10 to 15% had side effects. And there are other studies that are looking at statins and diabetes, and the diabetic prevention study, 36% of patients over 10 years developed diabetes. Other studies showed similar effects. The Australian longitudinal study for women's health, 8,400 100 patients, they had a 17 to 51% increase in diabetes, which was dose dependent. And a finished study of 8,700 patients over 6 years, there was a 46% increase in diabetes. So when you look at the statins in primary prevention, and this again goes back to the Newman meta-analysis report that was published in JAMA, no lives are saved. 1 in 100, treat 104 people to prevent one heart attack, and you had to treat 154 people to prevent one stroke, where you, at least in this study, had a 1.5% chance of developing diabetes, and 10% had muscle damage. Secondary prevention is a little bit more encouraging. Again, this was a meta-analysis of 100,000 patients over 5 years in patients who had known cardioarterial disease. 1 in 83 lives, or 1 person out of 83 people treated had a life saved. You had to treat 39 people to prevent 1 heart attack at 2.6%. and 125 people to prevent 1 stroke. In this study, 1 in 167 people developed diabetes at 0.6%, and 10% were harmed. So his conclusions were that as a public health measure, statins seemed to help, although the chances of a single individual being helped were small. 19 out of 20 people who took the drug over 5 years had no effect. But when you look at it from a population point of view, 1 million out of 1 million people who take the drug, 45,000 people will have some benefit, and 6,000 people will see some harm. So that's the glass half full. If you look at the glass half empty, 949,000 people were treated unnecessarily, or at least did not benefit from the treatment that they took. Let's put it in perspective. When you look at lifestyle, Mediterranean diet reduced the risk of heart attacks by 30%, which was 3 less events over 1,000 patient years, which was fairly competitive with statin use. Exercise, a 42% reduction in cardiovascular events, but even better, a 31% decrease in cardiac mortality in cardiac rehab programs. Smoking, a 36% decrease in mortality for those with CAD who quit. And stress reduction, a 22% decrease in events in the intervention group. So there is no study that I'm aware of that put all of these lifestyle changes together to see if there was a synergistic decrease in cardiovascular events. But my guess is that no one can say that lifestyle is not competitive with medication treatment. Well, cholesterol is not the villain. It is certainly a participant. It may be the gun, but it's certainly not the bullets or the trigger. And statins are really not the cavalry that come in to save the day. They have a function, they can help, but they're not the whole answer to put all of our focus on. So let's look back at least at what the function of lipoproteins are, because they really probably have more function than just as a lipid transport protein. And there's some good data to suggest that they play a protective role in infections and inflammations. And you can look at this slide later at your leisure, where they measure the phospholipid protein and how it binds to lipopolysaccharides, which are the cell wall of bacteria, how HDL has a higher ratio. And it's interesting. I've always wondered why, when I see patients' cholesterol levels who present to the emergency department, how they're always higher than the cholesterol levels that I have done in my office. And I'm wondering if that has something to do with the inflammation or stress of the disease that prompted them to go to the emergency room to begin with. So there really is a new way of looking at dyslipidemia. There are really 3 reasons for it. And it's not like in obesity, where I think we're moving away from this calorie in, calorie out concept. This is not just high cholesterol equals atherosclerosis. It's really inflammation, immune dysfunction, and oxidative stress that drives atherosclerosis. And these three reactions, or these three insults actually, are what prompts a vascular response that leads to atherosclerosis as in some ways, a healing event. The three things that most commonly cause these responses are chronic inflammation, and you can see that some people claim that atherosclerosis is really a postprandial event just from eating. And we'll talk a little bit more detail about others, things that can cause this. Chronic infections. Interesting, I've always wondered, well, why does Kawasaki's disease cause coronary aneurysms? And we all know that the literature is robust with linking periodontal disease with coronary artery disease. And so chronic infections play a role. And then there's toxins, pesticides, heavy metals, all those things that are also causing either an oxidative stress or a inflammatory response. So, we are moving away from the gastrointestinal tract as being an inert tube. Now with the microbiome and the dynamic ecosystem that we live with and how that affects our brain and our heart and everything else, it's no longer just a conduit of nutrients and waste. And just similarly, the blood vessels are not inert pipes, and they are full of receptors, and you can really think of them as the immune barrier after the skin and the gut. And the vascular system responds to insults in three defined ways. So here, of course, when you have biomechanical stress with high blood pressure or blood flow, yes, that causes injury and that can lead to atherosclerosis. But let's look at the biochemical list. And there are humoral factors, microbial factors, nutritional factors, antigen presentation, and environmental toxins that will stimulate receptors in the vascular tree that will then lead to either inflammation, oxidative stress, or an immune response, which in turn then leads to endothelial dysfunction, vascular smooth muscle dysfunction that leads to this cascade of events leading to atherosclerosis. So looking at the inflammation, I mean, how does that affect the vessel? Well, there are receptors called DAMPs, which are disease-associated molecular pattern receptors that recognize molecules and byproducts in the bloodstream and then react to them. And that could be tissue injury from anything from an injury to overexercising, metabolic states like hyperglycemia, sterile antigens from protein malformations that can lead to this. Lipopolysaccharides from intestinal permeability after you eat. Probably the biggest one would be modification of LDL, oxidized LDL, that stimulates these receptors leading to an inflammatory cascade. Similarly, the immune system has PAMPs, pathogen-associated molecular patterns, where receptors like toll-like receptors, TLRs, will identify sequences of the microbe and then lead to T cell activation in the in the vascular wall, leading to an immune cascade, whether it's complement or T cell activation. And then there's a oxidative stress, and there's just a huge amount of things that can cause oxidative stress. And again, living is an oxidative stress. So we're always oxidizing things, and that's what the whole balance of vitamin C and vitamin E and all those things is to, reduce the proteins that have been oxidized, and that even just happens in the energy transport system, just creating ATP creates free radicals, and that's where CoQ10 and vitamin E and vitamin C take a place to reduce that in the mitochondria. So ischemia, high blood pressure, heart failure, diabetes, mercury exposure, nutritional insults, and stress through catecholamine excess all can kind of get that oxidative balance out of alignment and have you have all this free radical take place, generation take place, causing cellular injury. And when you look at it, again, at least from the immune aspect, some interesting things. I won't go through all the details of this slide, but you can see that TLR2 and 4 are on the cell wall and will react to bacteria and oxidized LDL to bring in monocytes, create macrophages, get into the foam cells, and then you all know that cascade of atherosclerosis. But interestingly, angiotensin 2 stimulates angiotensin 1 receptor, and that activates CD4 cells that generate interleukin 17 and start an immune cascade. So one has to wonder, do ACE inhibitors work by lowering blood pressure, or do they work by decreasing inflammation in the artery? Interesting. So we are focused as medical providers on the top 5 risk factors, but there's hundreds of cardiac risk factors, of which 25 are modifiable. Yes, hypertension, dyslipidemia, hyperglycemia, obesity, smoking, all play a significant role, but there's more. And you have to wonder, well, what about those 949,000 other patients? What was the cause of their atherosclerosis? Was it low fatty acids? Was it high serum iron? Was it environmental pollutants, heavy metals, homocystinuria, hypothyroidism, immune dysfunction, the stress of sleep, lack of exercise, intestinal permeability, causing a leaky gut? And so, we need to start looking deeper into the genesis of inflammation, oxidative stress, and vascular autoimmunity to really understand where the problem is coming from. What is the gun, bullets, and trigger? So in the level 1 program, we touch on all these areas. Now level 2 program will take a much deeper dive, and we will be talking about that later. But you do want to know the waist-hip ratio. That's probably more indicative of a cardiometabolic problem than just doing a BMI. And it will help determine whether you have an excess of visceral adiposity or whether you really just have subcutaneous adiposity. And that's really quite different. Visceral adiposity is an inflammatory condition, affects adipokines, starts to recruit macrophages or monocytes and macrophages in the vessels, and leads to a whole cascade of problems. Again, you'll have the opportunity to do advanced lipid testing with LDL particle numbers and LDL size, and taking a little more comprehensive picture of what the lipids are doing. Again, LDL particle number, it probably is more a better risk indicator than just an LDL calculated number. Metabolic testing, of course, you need to know about glycemic control. There are other metabolic tests that we would do in the level 2, but glycemic control is absolutely critical. Inflammatory testing, just using the CRP will give you some information, but there's a whole host of other inflammatory molecules that we can test that can give us an indication of what the person's risks are. Nutritional analysis is pretty important, and again, it's somewhat superficial in the level 1 program, but in a study done recently, or not actually some years ago, but showed that 80% of Americans had at least one nutritional deficiency. And when you look at the cardiovascular drugs we use, you can see that many of them are also, you know, cause nutritional deficiencies. And for just an example, at least in diabetes, metformin reduces B12, while statins reduce CoQ10. So when you look at all the beta blockers, actually reduce CoQ10 levels as well. So there's a whole host of nutritional issues that could be part of this cardiovascular epidemic. And then looking at end organ damage, to have something to measure. I mean, what's their carotid artery thickness? Do they have plaque? I mean, we can do that easily and see, well, gee, how aggressive do we need to be? So this is a comprehensive heart plan. You'll be able to do advanced testing, but we really do need to focus on the lifestyle with our health coach to address the nutrition, exercise, stress, sleep issues, relationship issues of our patients. That has a profound effect on their health. And then focus on, what is the etiology of the insults causing the atherosclerosis? Are they inflamed? Do they have oxidative stress? Do they have a vascular immune dysfunction process going on? Again, this is how we have to think about it, not just whether they have high cholesterol and high blood pressure. That's just too limited in thinking. And then where do we head? Well, in the future, we'll be doing genomics, although it's not prime time now. ApoE is interesting because it can tell you whether someone needs a low-fat or low-carbohydrate diet. But the but you have to be aware that there's some risks right now. There are no discriminatory protections for genetic testing. So that's a legal issue that I think we have to be quite careful before we do genetic testing on our patients. But there are other tests that are coming up that are probably going to be better than genes, which really are not really where I think we should be putting our focus. There's a test called Chorus where you're actually looking at our RNA metabolites, more of a proteomic, metabolomic type of look to see what one's risks are about, not really what the DNA is, but what is the DNA doing. And so that's actually available now, and more of those tests are certainly on the horizons. We could look at cytokines now through certain laboratories, interleukin 1 and 6, to really see, well, is this person inflamed? CRP does not tell you everything. And again, there's more advanced diagnostic testing with TMAO and lots of other tests to really help discern, where is the problem coming from and where should you put your time and effort to intervene. I mean, it's more than just trying to identify those 950,000 patients who did not benefit from statins. Even when you are treating people with statins, I can't say that it's a robust success to have 35% reduction in cardiovascular events. I mean, what about those 65% of patients who failed statin therapy? So again, this is where we're heading. This is personalized medicine, individualizing the care to the patient. We're going to learn more about exactly what these tests are, how to use them properly, and in the following modules. Thank you.